evening and welcome everybody joining the call. My name is Ribeiro-Addy and I'm the Member of Parliament for Streatham. I'm very pleased to be chairing the first part of this conference, the Pandemic and Privatisation, How to Fight Back. Over 1,000 people have registered to attend this event, which is fantastic. Now, we all know that the Tories government's handling of the pandemic has left us staring at the worst economic shock of any OECD country and the highest death toll in Europe and the highest per capita death toll in the entire world. They were slow to realise the threat posed by the virus, slow to acquire life-saving equipment, slow to take action to safeguard human life against the virus, and their hesitation to adopt bold policies and follow the example of other countries during a public health emergency has left us all worse off. We often heard fighting the pandemic described as a war, and if we are fighting a war, we've been doing this with one hand behind our backs because the NHS, like most of our public services, has suffered the effects of austerity and has been starved of resources. Now, throughout this period of time, past decade, we've seen the privatisation of the NHS, small parts of it, but the pandemic has opened the door for more privatisation by stealth. The government keep assuring the public that the NHS is not for sale, but we know that US health insurance giant Centene, for example, has already taken over 49 GP surgeries in London alone. So that's yet another hollow government promise. 130,000 people have already died from coronavirus in the UK, and we know this is not the final count. And I want to be clear, because the successful rollout of the vaccine has been a distraction to this very serious death toll. But any success of this vaccine rollout is not a success of the government, it's a success of our National Health Service, an example of what it can achieve when it's given the resources it needs. Our NHS really is one of the best things about this country, and we have to do everything we can to protect it. So now we know why we are here. I'm going to go to some housekeeping. This event is being live streamed, but only people participating via Zoom will be able to participate in the workshops. So you may wish to go to the Health Campaigns Together website and register to join us via Zoom if that's not how you're watching at the moment. I know many of you will be used to Zoom meetings by now, with the most common phrase of the year being "you're still on mute," but I want to run through some of the specifics about how this meeting will work so everybody's clear. My co-chair is, as we speak, posting a link in the chat to an accessibility guide that will also be circulated to attendees in advance. We have captioning and a full transcript enabled for accessibility. The best full transcript is available via the live button and open custom live stream. Alternatively, you can access Zoom's built-in transcript via the CC Live transcript button. On some devices, you might find this under the More button or via meeting settings. If you find the subtitles distracting, however, you can turn them off via the same route. Because Zoom chats can get very, very busy in a large meeting and cause accessibility problems for some people, we have gone down this route. So unfortunately, there is no option for people to hide it fully. The chat is actually disabled for participants, except for in the workshops, and it will only be used for announcements from the facilitation team. As an alternative, we have a discussion page. You can post events and links and discuss what the speakers are saying, etc., all through that time. So my co-chair is now posting that link into the chat box now. We're going to hear from a few speakers, then move into the workshops where everyone can contribute, then get back together for the two final speakers. And each speaker in this session is going to have 5 minutes to speak. As we're on Zoom, I can't pass you a note or nudge you, so I have to briefly interrupt you to let you know you have 1 minute left and stop you after 5. And we ask you to please stick to the time. We're keen to be on schedule. My co-chair will mute anyone if necessary, but I hope that won't be the case. So we're going to go straight to our first speaker, so we can keep to time. Our first speaker is Paul Evans, and Paul is the director of the NHS Support Federation and co-editor of The Lowdown. Paul.
Good evening. It's great to join you all here. Even though these are exceptional times, the surge in the use of the private sector during the pandemic stands out as a key feature of the government's response, But with so much public money at stake, what was the rationale? It was crucial to get the test and trace system up and running quickly to protect people and contain the virus. But the government opted for a centralised system, placed it broadly in commercial hands, ignored the 40 NHS labs, and left many NHS scientists frustrated that they couldn't contribute the testing capacity that they had available to them. And in a similar way, tracing was handed to Serco and Cytel, ignoring the local expertise within public health, which could have been expanded on. And of course, council-run contact tracing, when used, consistently outperformed the centralised Serco-run operation. And the failure to get the outsourced test and trace system up and running quickly left the independent SAGE group of scientists in no doubt that this strategy had undermined the response to the virus and cost lives. But before the pandemic, there was already evidence telling us that public services get worse once outsourced. A study across 130 NHS hospitals of the impact upon cleaning services described the outsourced version as cheaper but dirtier, with a drop in quality and an increase in MRSA infections within hospitals, some of which have led to unavoidable deaths or avoidable deaths. A study of the Scottish NHS found that increased use of the private sector was associated with a significant decrease in NHS provision and a widening of inequalities. And of course, in England, over the last decade, we've seen an extensive and at times wild experiment with outsourcing, which has sharply exposed the fundamental issue here, that financial interests of a company will inevitably diverge from the best interest of patients and the NHS. And not only that, there are now repeated examples of where we have failed to manage this incompatibility through contracts. We saw it early on as companies frequently terminated NHS contracts that were unprofitable. It happened in GP services, leaving patients to find new surgeries. We now see digital providers of GP services picking younger, cheaper patients and the NHS funding that goes with them. And we've seen patient transport contracts abandoned, once at very short notice, leaving cancer patients to get taxis to their treatments. And of course, the infamous attempt to allow the private company Circle to run a whole NHS hospital in Cambridgeshire, ending in damning criticism by the watchdog, failure to make the promised savings and the passing of the contract back to the NHS. Staff are affected too, mostly acutely in support services that deliver essential security, cleaning and laundry services, where outsourcing has forced regular disputes over terms and conditions and issues of staff safety. Thankfully, despite 8 years experimentation with competition, the NHS is still the main supplier of clinical care, but we should be wary of ministers minimising privatisations. In some parts of the country, local commissioners spend 26% of their budget on non-NHS providers. Nationally, we certainly underreport the expenditure on the independent sector. And there are areas of the NHS where the private sector has got a strong foothold, and these serve as a warning. In mental health, 40% of the budget for child and adolescent mental health is spent on private providers, and yet children with eating disorders are travelling to the other end of the country or waiting months to get access to talking therapies. Outsourcing has not led to the ample supply of mental health care. The NHS is reliant on these companies, and that's despite the fact that the CQC has rated some of the services as inadequate. These are all clear warnings about what happens when the NHS chooses to fund healthcare but not to provide it. There's now a choice to be made. The NHS will come out of the pandemic woefully understaffed on the back of a decade of underfunding. Unbelievable after all of its efforts. More than ever, it needs investment in people, buildings and equipment that is sustained for the long term. But watch out, because outsourcing is associated with periods where public funding is under pressure, when governments often choose to bank on the cost-cutting nature of the private sector. Despite the media that report the government is turning away from competition in the NHS, there are absolutely no guarantees that this will mean less outsourcing. Matt Hancock has already confirmed that the private lighthouse labs will form the foundation of the future of NHS diagnostics. So there's a fork in the road. We have to continue with the partners that share our ideas and principles. As citizens, we all share the risk of ill health through a tax-funded NHS. In return, the NHS treats us all when we need it. But can privatisation and the private sector deliver healthcare for all? The evidence and the experience says not. Thank you.
Thank you very much, Paul. We're now going to go straight on to our next speaker, who is Pascal Robinson. Pascal is a campaign officer at We Own It, which campaigns for public services to be in public ownership, run for communities and not for profit. Pascal.
Thanks very much, Bill. So yesterday, Rachel Reeves asked the Health Minister and previous Serco employee Edward Arger to apologise to frontline workers who had been required to make their own PPE. And Arger said that he makes no apologies for the government doing everything in its power to ensure NHS and frontline workers did not run out of PPE. But we know the reality is that this couldn't be further from the truth. And I think our ministers still don't really understand what happened there. The NHS supply chain was outsourced in 2006. So a mishmash of private companies are responsible for 11 different product areas. And when the PPE crisis came up, their thinking was, didn't I pay someone to deal with this? They had to save face, so they brought in Deloitte to manage extra PPE sourcing. But Deloitte designed the outsourced NHS supply chain that had failed so catastrophically in the first place. We didn't have enough PPE at the start. The NHS supply chain rationed shortages and stopped NHS trusts ordering extra supplies. They gave 2 billion, the government rather, gave 2 billion worth of contracts specifically to their mates, their contacts. And we saw contracts go to those with no experience, those who said that's not my area actually, resulting in millions of units of PPE not being safe enough to use. Edward Arger laughs in our face when he says he did everything in his power to ensure that NHS workers had enough PPE. And our report into this showed that the privatisation of the NHS supply chain led to fragmentation and a prioritisation of profit over working systems and extra capacity. We need our NHS supply chain back in-house. Moving on, this government wholeheartedly believes that plucky young people with a few million in their pocket or a career in consultancy can save the day. But it's been made clear time and time again over the past year that experience and a feeling of duty to the communities you serve is key to delivering a health service. This was not learned when we went on to track and trace. We Own It's been running a campaign calling for local public health teams to run that. But rather than doing that, boosting local public health teams who have years of experience in contact tracing and an immense amount of knowledge about the communities they serve, the government employed Serco to set up remote call centres hundreds of miles away. Serco's system, as we know, was sometimes only reaching 50% of contacts, and this meant that the virus was blossoming out into every community in the UK. It was meant to stop a second lockdown, and now we're, of course, on our third and many, many awful deaths. Even now, it's only reaching 70% of contacts outside of the household, and that's 9 months in. It's still not reaching sage contacts. Public health teams, by contrast, have reached over 97% of contacts. And we know that it's had a marginal impact on transmission. Rupert Soames, the CEO, he was and isn't ecstatic. He has cemented the position of the private sector in the NHS supply chain just as he wanted, just as he said in that leaked email months ago. And of course, we found out today that their revenue has picked up. They've hit 3.9 billion and they're going to start giving money out to shareholders. This news is despairing, but thousands across the country have campaigned to stop this and to get local public health teams funding. That you have written letters, called Matt Hancock out on every platform, passed motions, held protests at 25 different town halls across the country, and you demanded not a penny more to Serco. And now millions more in cash has been given to local public health teams, and there are trials in test and trace now that positive contacts will go straight to knowledgeable local public health teams, that no Serco involvement. This isn't enough, but it is progress, and campaigners like you here tonight made that happen. When we asked our supporters in January, over 3/4 said that they want us to fight for the NHS together. We cannot accept the government's line that to deal with this pandemic, we need to bring in so-called expertise from the private sector. Every part of the pandemic response that has been led by the private sector has failed, and this has cost lives. Meanwhile, vaccines, of course, run in NHS hands, has done really well, and we need to highlight that every single day. Privatisation has always cost lives through the inherent need to prioritise savings and profit over people, their accountability to shareholders over citizens, and their cherry picking of services over providing universal access. We need to fight against the takeover of our health services, whether it's multinational Centene, which is known for shutting GP practices that aren't profitable, or whether it's this white paper, which lets private companies sit on decision-making boards. I just ask that everyone here tonight gets involved in the fight for our NHS. I'm sure you already are, and please get involved in We Own It and support all of the other campaigners here tonight. And thanks very much for listening.
Thank you very much, Pascal. We're going to go straight to our next speaker. We have James Anthony. James is the Vice President of Unison and NEC member for healthcare, as well as being a clinical nurse specialist in the NHS in Birmingham himself. James.
Thank you, and thank you for the invite to speak today. I think it's really important, and I'm in 2 meetings at the moment because we've got a strike rally going on in my own NHS trust, where there's a group of porters that actually we've managed to win to come back into the health service. They were employed by G4S. They're now employed by the NHS, and unfortunately feel like they've been treated worse by the NHS than they were by their private sector employer, which is pretty shocking. I'm sure you'll all agree. And sometimes we get accused as campaigners, as trade unionists, of overhyping privatisation and making it sound like a bigger problem than it is. But as we've heard already tonight, it is a real problem in lots of areas of the health service. And one of the things I've been asked to particularly talk about is a real threat that's affected lots of our members, which is the setting up of subsidiary companies. These get called wholly owned companies, or as well as subcos, and have been sought by trusts specifically in England as a way of cutting costs. One of the ways they do this is, in essence, it's tax avoidance. So it's using a loophole in the VAT system that these subsidiary companies won't necessarily have to pay the same VAT as the trusts, and they use that to save costs. But also, it sets up two-tier workforces, something we've campaigned for many years to get rid of, and achieved NHS-wide collective agreements that covered all groups of staff. But now we're seeing particularly facility staff spun off into these semi-private companies, but also staff like pharmacy and other staff. And I suspect in the long run, it will be clinical staff affected as well. But obviously they go for these staff because they don't get the same headlines. And that's why we always stand together and say, actually, we're about one team in the NHS, and every part of that one team, whether it's myself as a nurse or the porters that I was talking about earlier, the cleaning staff that make it safe to do my job and to look after patients, every one of them is important. But this is quite a sneaky form of privatisation. As though the subco does belong to the NHS, it is treated and behaves like a private sector company going off trying to win contracts, often from other NHS trusts. So trusts will often try and sell this to their staff as a better option than outsourcing, as an alternative to putting services out to tender. But they don't need to be put out to tender in the first place, because as we've already heard, that will be worse quality. But they go out, they get a different name, a different identity, and feel less connected to the NHS. They're broken away from their colleagues and co-workers, not feeling part of that team when they're employed by a different entity, unable to state unequivocally that they work for the NHS. And they've had a really damaging impact on the workforce, serving to demotivate and demoralise essential healthcare staff who are already overworked and underpaid. And these shortages are well known. So anything that damages further recruitment and retention is a real own goal. And the whole subco agenda runs against all the claims about bringing greater integration into the NHS. It is just a way of fragmenting services. And individual subcos go on about their own tax avoiding initiatives rather than working together with others. And we see more competition rather than cooperation. At one point, virtually every region in England was affected by this ruse. But in many ways, the story of subcos represents a good story in fighting back. Unison have been working tirelessly on this with other unions and many local campaigns, and thanks in particular for Health Campaigns Together for helping us publicise these campaigns and events. And as a result of all this campaigning, we did manage to turn the tide. It really began with workers themselves up in Wrightington, Wigan and Leigh saying that actually this isn't acceptable. We're not just going to take this lying down and be transferred out of the NHS, that we want to be part of that NHS family, and believed it so passionately that they were prepared to not just campaign, but take really significant industrial action that won. And we got an agreement that those staff would not be transferred out. And we've had similar victories right across the country. And as a result of strong political media and industrial campaigning, it forced the NHS nationally back to the table with improved guidelines and restrictions on trusts. But the problem hasn't gone away. Even in the midst of the pandemic, there have been trusts considering doing this type of privatisation. Locally here in the West Midlands, we've had trusts proposing transferring their whole IT services out to these one of these subsidiary companies. So it certainly hasn't gone away, and it's something that we need to be very, very vigilant about. And that shows we can never be complacent. It's really important that we continue to work together as campaigners, patients, staff, all together to say that we will fight privatisation in all its forms. Thank you for the time this evening, and good luck with this event tonight. Thank you.
Thank you very much, James. And please send the solidarity of the hundreds of people at this meeting to your members. Thank you. Our next speaker is Lola McEvoy. Lola is an NHS organiser with the GMB. Lola.
Hi, evening all. Thank you for having me. For many years, all of us, every one of us on this call, have been fighting for those who clean our hospitals to be back in the care of our NHS. In too many trusts, we failed them. Outsourcing our staff is cost effective. Not only do you not have to worry about uniforms or timetables, you can completely wash your hands of any duty of care for the well-being of your lowest paid workers. Trusts have time and time again turned a blind eye, leaving it to the bravest cleaners and porters to risk their jobs to organise their colleagues and fight contract by contract for what they deserve. It's grim when you think that it's taken a global pandemic for them to be seen again. Early last year, I remember calling up a mentor of mine and asking them if they thought it would be sensationalist or alarmist or too much to highlight the link between poverty sick pay and its potential risk to our hospital members' lives. Little did I know that 12 months later we'd have the worst death rate in Europe. Needless to say, he backed us and we won full sick pay commitments from the UK's biggest service providers, backup funding from the government, and a withdrawal of the draconian unpaid waiting days that most minimum wages workers have to endure when they're ill. It's taken this crisis, but right now, NHS outsourced members are being seen. They're in the forefront of the public's mind. We, all of us, have a tiny window to make sure that the financial hardship they've faced over the last 10 years and the unthinkable mental and physical strain they've endured over the last 12 months isn't for nothing. It's not in vain. We, all of us, can act now. This government will use the national cost of COVID to justify yet more carving up of our NHS. Only this time we won't have the EU to keep them honest. We're facing a generation-defining recession amidst a global pandemic whilst rewriting our own legislation with the most inept and unaccountable Tory government calling the shots. For us to expect this government to voluntarily mirror EU public procurement transparency principles would be naive. In the same breath, for us, the UK's brightest and best NHS activists, to be unprepared for what's coming would be unforgivable. We've got to work together and pool our collective knowledge and resources to create a hive mind and protect our NHS. For efficiency, we need a working collaborative, a live database with procurement profiles of every trust across the country. For transparency, we must research and share our trust's current and future arrangements, sell our NHS cleaners and porters out to the unaccountable private facilities management providers, with added scrutiny on the wholly owned subsidiaries. On this call tonight, this Zoom conference, we have the best and the most knowledgeable public health procurement experts. I know I'm biased, but it doesn't mean I'm wrong. We need to harness your knowledge, combine that with our trade union movement's collective industrial strength, and we can succeed. We can protect our frontline key workers and their families, just like they've protected us these last 12 months. So here's how we do it. If you're up for it, send us an email. You can do it right now. It'll take you 5 seconds. Send an email to nhs@gmb.org.uk. Put transparency activist in the subject line, and we'll send you a campaign pack with template letters and research questions we need answers to that the public can get from our trusts whilst they're still accountable to us. We've got to act now. We've got a small window before this white paper gets written up, whilst our trusts will still answer, whilst they're still accountable to us, the public, who support, use and fund this unrivaled national service. Together, we know we're stronger. If we can collaborate, we can use our shared power to apply public and industrial pressure and protect our NHS, our key workers and our communities from Matt Hancock and his private contractor cronies. Thank you. Send the email.
Thank you very much, Lola. As she says, send the email. Our next speaker is Ian Evans from my own union. He's the chair of Unite's Healthcare Sciences National Organising Professional Committee. Ian.
Good evening, everybody, and what a wonderful event, and thank you for giving me the opportunity to speak. First of all, I have to probably give a bit of an apology. As you can probably tell by the magnificent background, I'm still at work. And again, I'm second on, so if any alarms go off and I run away, you know it's not on purpose. It's been a remarkable 12 months. On the 24th of February last year, David Wells, the head of pathology for NHS and I, received a phone call to say, this could be bad. We might have to do an extra 500 swabs a day for the virus. So that was the plan. Yesterday, we actually tested 718,063 people, most of which come back negative, which is great news. The problem there on that one is we just didn't have the capacity to do that to start with, largely down to the NHS that these tests are being done. As you know, the private sector are very much engaged in this one. So again, I'm here to speak about the mega labs and the NHS and again, what the future is going to be. I want to put a bit of context on this and go back and what the year we've had. It's been an extraordinarily difficult year for everybody, but within the pathology profession, again, it's been nothing short of remarkable. When we started taking this all on, there was this massive design, this massive investment for the private sector to pick this up. And again, they were given a lot of money, a lot of new equipment, and a lot of space. And again, they were expected to hit the ground running. They failed and they failed miserably. It was only then when they realised that, again, we were seeing literally, you've already seen it, there was a lot of labs across the country, a lot which are specialised in viruses, but also within other pathology disciplines, we are able to pick up this work as well. We were ignored. My trust was asked to carry some of the weight. We did, we took it on. We have shoehorned in equipment all over the building, all over the lab. This is probably only free space that we have now, which is not got a machine in it. We did pick up the work. We was successful. We did make a difference. The same can't be said for Pillar 2 or the private sector, who dithered. They had lots of shiny machines in there. They had lots of students in there. They had nobody who actually knew how to operate the equipment. So a lot of it stood idle. And again, so more work kept coming our way. It keeps coming our way. And it got to a point where last year, all the staff that was recruited in Pillar 2 all went back to university because they didn't actually have any real staff. They only had temporary staff. There was only temporary contracts. So again, the work came our way again. This is only now starting to actually change. And again, as we come towards the end of the pandemic, as the vaccination program is now starting to work, we're actually now starting to see that the Pillar 2 labs are actually starting to get their act together. So what you will see is, again, they're now looking professional, they're now looking sleek, they're now looking the part. The reluctance about this one is that, again, they're now setting themselves up to be out there for any future work. As I say, the pandemic work will diminish. However, there's been a significant amount of investment on equipment and facilities, including transportation, and again, eventually will be integrated limbs. So again, management systems to communicate the information for work they receive, and they will start demanding. There will be expectation for them to receive the work. Now, the thing is that they won't just take any work, they'll cherry pick the work that they can do, the work that they can turn around cheaply and quickly. They will use automated platforms, and again, this will just take unregistered staff, just to load a machine and hope for the best. And again, this is the way they're going to perform. Now, results will take time to get out, clinical decisions will be delayed, and again, this will only be the simplest of tests. So again, this is a profit-driven system. We in the NHS, but again, we'll have to pick up the pieces. We still do all the complicated work now. We still do the highly skilled work now. We still have to maintain our equipment now because we don't have living engineers. So again, the equipment we have received over the last year as well has been second-hand, outdated, falling apart because the private sector didn't want it. So we have continued to struggle. This is our future. This is what's going to happen. This is what's going to be the drive. As you know, the Milton Keynes lab was largely set up by Deloitte, so it was set up by financiers. And again, they didn't set it up because they have an interest in health, well-being, and caring of the general public. Their interest is based around the need for profit. And then I use the word need because that's all they want. This is their design. They have shareholders. We've heard other speakers tonight talk about the 49 GP surgeries and again how the private sector is coming in to take over there. And again, we've seen this already with labs across London and again further afield as well. This is going to continue to happen. We've had a centralisation of services for quite a long time now, and again, this is going to continue to happen. All the time this happens, all it will be based around is what can be done quickly, what can be done cheaply, and how can we do it cheaply. And again, this will result in staffing skill mixes changing as well. Somebody used the term brain drain. I'm not too keen on it, but it probably is. It's probably an adequate and an appropriate term. So what we're going to see now is that the lack of registered staff undertaking duties, the lack of registered staff releasing results, and again the lack of professional staff and registered staff to actually give clinical advice to any doctors, nurses, or any other medical professional that needs it. So again, what we will do is maybe have a call centre for results going out for an automated platform. We're in very, very dangerous times, but this design is very strong in the government, and again, they will continue to push for this. So it's wonderful to be at an event like this evening, just to get the story of the scientist across. Again, that there's not a lot of us in the NHS, but there's still a good number. But we are responsible for around about 70% of all clinical decisions made based on the work that we do. So thank you for your support, and again, I really do hope you enjoy the rest of this evening. So thank you.
Thank you very much, Ian. Our next speaker is Dr. Sonia Adesara. Sonia is an NHS doctor and active in Keep Our NHS Public. Sonia.
Hi, everyone. I think I may have drawn the short straw in getting the topic of management consultancies. It may seem a bit dry, but it's really important. So bear with me for the next 5 minutes. And unsurprisingly, management consultants are another group of people who have done rather well in this pandemic. So on the test and trace system, management consultants were paid 375 million. Deloitte consultants working on the trace system were paid on average £1,000 per day. The Boston Consulting, it's a team of 5 people, were paid £25,000 per day to, on quote, mastermind the creation of the tracing system. And as we have seen, the result of these highly well-paid masterminds was a test and trace system that has been shambolic, dysfunctional, and, you know, with no doubt really has contributed to us losing control of this virus and the second wave and the preventable lives and livelihoods lost as a result. So I think firstly, what I think is important for us as NHS campaigners to be thinking about is how they think about these structures and the mechanisms that were in place that allowed this to happen, that allowed the pandemic to be exploited, that allowed these public funds to be siphoned off to shareholders, that allowed these £1 million contracts to be given to friends of the government. Now, the use of consultancy in the NHS, which many of you know, is not new with this pandemic. Their role goes back to the 1970s, and the sums of money being spent on management consultants range from the extortionate to the just utterly ridiculous. So in 2019, NHSE paid PA Consulting £200,000 to, and this is not a joke, they paid them £200,000 to tell NHSE what NHSE were responsible for. Now, this would be comical if this wasn't our money, if this wasn't taxpayers' money that's being wasted like this. And it's even less funny when you're working on the front line and you're working in wards like mine where half our computers don't work, when you have out-of-date equipment, and where you see patients being harmed as a result of this gross underfunding, and yet we are told that there's no cash available. And the second thing I wanted to think about is influence. So McKinsey, which is one of the big 5, one of the government's favourites, they were used they were used to devise the Andrew Lansley reform, so the disastrous, utterly disastrous Health and Social Care Act of 2012. They were used to construct that. And this influence of management consultants in policymaking is expanding. So we've seen with the integrated care systems, there's a push for them to be involved in the construction of how these will work in the organisation. And, you know, if we are using private corporations to influence policymaking, if we are using them to construct and organise our the delivery of our health and care system, then we shouldn't be surprised if they are constructed in the ways to exploit profit, which is of course what we saw happen with the Health and Social Care Act. And we need to remember that we are privileged in this country, not simply because, you know, we all have access to this free and world-class healthcare system, but we are privileged because we know, you know, when our family members, you know, use the NHS, we know that we have trust in the system, that their care is the #1 priority. And when you allow the influence of those who want to profit from ill health, that is what's at risk of being undermined. And finally, I just want to make a broader point, and it's touching on what others have mentioned, but we have seen in this pandemic just, it's shocking, it's gross government corruption. And I'm concerned that these repeated, the headlines and the huge numbers, I'm concerned that the public are becoming numb to this, But we cannot allow this misuse of public funds to be normalized. We cannot allow this cronyism to become an accepted part of public life, because not only will that undermine public's trust in the state and in our public services, but it has, I think, really dangerous consequences for the health of our democracy as well. So I'll end on that cheerful note. Thanks for having me, and I really look forward to the discussions later.
Thank you very much, Sonia. We're going to move straight on to our next speaker, who is David Rowland, and David is the director of the Centre for Health in the Public Interest. David.
Hello, and thank you very much for the opportunity to speak to you all tonight. It's a real privilege to be talking to so many people who are genuinely and rightly concerned about the future of the NHS, and particularly concerned about those issues relating to the private sector, which, it has to be said, are not particularly well understood within the media, and not particularly well understood within Parliament. And what I'd like to do this evening is to just talk briefly about work that we've been doing at the Centre for a number of years, which relates to the engagement between the NHS and the private hospital sector. So I want to talk just briefly about the situation that the private hospital sector and the NHS were in prior to the pandemic, then talk through about some of the arrangements that have been in place during the pandemic, and then just to give some thoughts about where the direction of that relationship is likely to be heading in the future. So despite what is often stated within the media and amongst policymakers, and often also by other think tanks, the private hospital sector in the UK, the multinational owned private hospital sector which operates in the UK, doesn't provide additional capacity to the NHS. In fact, it is really entirely reliant on the NHS to be able to deliver both the income that it generates in order to keep going, and also to produce the profits for its shareholders, as well as to ensure that it delivers on the rent and other debt repayments for those others who are engaged in the private hospital businesses. And the way in which the NHS provides that support to the private hospital sector is really through allowing NHS consultants to work in private hospitals in their spare time. It also provides a significant amount of income to the private hospital sector. So you have some companies like Ramsay, where around 80% of their income is generated through the provision of NHS services. We also have a situation where the private hospital sector has patients where things go wrong. The NHS is there to provide backup arrangements. So most private hospitals don't have intensive care units. So in the event that a patient is needing treatment as a result of post-operative complications, the NHS is there to provide that support. We estimate that probably costs the NHS around £70 million a year in terms of additional subsidy. So just to be clear, whilst it is the case that the government has moved very fast over the past decade to increase the use of the private hospital sector in the delivery of NHS services, to the point where it is now the case that around 1 in 3 NHS funded HIP operations take place in the private hospital sector, it's very clear that the private hospital's business model is heavily dependent on the subsidies which are provided to it by the NHS. So that was the situation pre-pandemic. When the pandemic hit last year, the restrictions which were placed on private hospitals in terms of being able to treat patients during lockdown, as well as the travel restrictions which were put on place, which meant that lots of the overseas and more profitable patients weren't able to travel, meant that the private hospital sector in this country was in deep financial difficulties, as many businesses were. And so the NHS and the independent private hospital network signed an arrangement whereby the NHS would pay at cost for the entire private hospital sector's capacity. Now, we still don't really know how much was spent on that arrangement. The government has, as in many cases, not been fully transparent about the nature of that contract, nor do we know exactly how many patients were treated in response to that. However, there are estimates that the private hospital sector received about 850 million to £1 billion. And what we are also starting to hear is numerous reports about the fact that the actual utilisation of private hospitals by the NHS during wave 1 of the pandemic was nowhere near what was the value of the actual contracts which were paid. So that was a situation which emerged during wave 1 of the pandemic. As we progressed through the pandemic, the relationship shifted somewhat because of the fact that the private hospital sector realised that it could start generating income as a result of the pent-up demand that came from the NHS being overwhelmed during wave 1 of the pandemic. And that meant that whilst the NHS wanted to have at its disposal lots of private sector facilities in order to treat particularly urgent cancer patients, the private hospital sector itself was concerned to ensure that it maximised its revenue through being able to treat less complicated, more profitable operations such as hip replacements, the meat and drink of the private hospital industry. And so as a result of this, the NHS was in a situation around the turn of the year where it was actually pleading with its own NHS consultants not to do work in the private hospital sector, but to focus their attention on treating urgent patients within the NHS. Or if they were going to be working within the private hospital sector, they wanted the private hospital sector to commit their resources to actually doing NHS work instead of doing private work. And really what this experience shows is that there is a codependency relationship which exists between the NHS and the private hospital sector, such that it's very clear that the NHS has lots of opportunities and lots of levers to be able to use that capacity which exists within the private sector in the ways that are potentially in the best interest of patients. So it could be argued that rather than simply renting the facilities from the private hospital sector, rather than using NHS consultants to do work in private sector facilities, that those private sector facilities at this time of a national emergency, and indeed in the future when waiting lists have grown so significantly, should be incorporated within the NHS estate. And this is something which has happened previously within the NHS. Those people who've been around long enough will remember that Robert Naylor, the former chief executive of UCLH and the architect of the government's capital investment strategy and a big fan of PFI, actually bought at lower than market cost a failing private hospital and incorporated it into the NHS because he saw that as a good use of public money. Controversial at the time, however, it's certainly the case that those type of policy decisions could be taken to incorporate private hospitals into the NHS rather than the NHS paying over the odds and subsidising the continuation of private hospital care. So I'll leave it there. Lots of things for you to consider. There's a lot of stuff on our website if you'd like to understand more about how that relationship works.
Thank you very much, David. Our next speaker is Jacqueline Williams, and Jacqueline is the Acting National Officer for Unite's Health Sector. Jacqueline.
Thank you, and thank you for the invitation to speak this evening. COVID-19 has cast a shadow over many workers that had previously been outsourced to private companies. And whilst working within hospital trusts, they are now not employed by the NHS. Those workers carry out jobs such as hospital porters, security staff, and catering staff, to name but a few. They're vital to the running of the hospital and support patients, doctors and nurses on a daily basis. Yet in some hospital trusts, they must have been either invisible or seen as unworthy of the regular lateral flow testing of all asymptomatic staff that was being rolled out in England towards the end of last year, despite them being in patient-facing roles. It's important that every single worker, be it a cleaner or a consultant, is treated the same. We cannot underestimate how damaging this is to NHS operations and to staff morale. Many of those workers are BAME, living in multi-occupancy households with vulnerable family members. And it was only after union pressure that this issue was resolved. We should be clear that not all employers went along with this approach, as some did ensure very early on that the workers received the necessary testing kits, but it does highlight that in a time of crisis, exactly what the effects are of fragmenting and outsourcing of the NHS. The effect on the BAME community has been seen by us all, yet a further expansion of outsourcing with no framework will lead to further division. The coronavirus pandemic has renewed focus on the public-private sector debate in its starkest terms, and we have seen with the successful vaccination programme how the NHS can deliver efficiently and effectively. What the pandemic has brought into sharp relief is that there can never be a market for healthcare. You cannot simply apply the harsh disciplines of the bottom line. If somebody needs vital treatment, it should be delivered in a timely and safe manner. There can be an end to outsourcing, and other nations are able to deliver outstanding healthcare without the need to hand contracts out to private companies. We all deserve better, and together we can make a difference. This is our NHS. Thank you.
Thank you very much, Jacqueline. And now we're going to go straight to our final speaker on this panel, John Lister. After John, we'll move into the workshops, and one of my co-hosts will post information about the workshops in the chat shortly. John is the editor of Health Campaigns Together and co-editor of The Lowdown. John.
Thank you. I've been campaigning against NHS privatisation since it began back in the 1980s. Yes, I am that old, but this is the biggest ever event of its kind, with well over 1,100 people registered. It's no accident that this level of concern comes after a year that reminded everyone how much we need the NHS as a public service, a year of government decisions to squander billions on privately provided systems. Many people now know that these systems don't work, like Serco Test and Trace, undermine existing NHS services like the Lighthouse and Mega Labs, put staff at risk by delays and shortages of PPE, or rip off contracts awarded to cronies and donors for PPE that's not fit for purpose, and divert billions in NHS funding to private hospitals, leaving thousands of NHS beds closed or empty. Just as we got plunging standards of hospital cleaning in the 1980s swiftly identified contracting out with poor quality of care for patients and brutal exploitation of staff, the response to COVID has exposed the unreliability and ineffectiveness of private solutions to the new problems. This helps us in our task of trying to unite the opposition to privatisation while dividing the enemy. Of course, it's not just about the acute hospital sector. We also need to roll back previous privatisation in mental health, community health, and most recently, of course, the takeover of 49 local GP practices by an American multinational. But pandemic privatisation is different from previous outsourcing. The services involved now are mainly new services or supplementary to the NHS, so we've got no groups of NHS staff being bundled out to cheapskate employers. So this gives us no immediate easy focus for public sympathy and trade union solidarity, although this could change, of course, if the privatisation of pathology services continues. But we need to focus on the often poorly paid workforce in the new services. To prevent mega labs poaching vital NHS staff by offering higher rates, for example. We obviously need a significant all-round increase in NHS pay, but we can also campaign demanding lighthouse and mega labs, which have been paid for with public funds, be taken over by NHS trusts, or at a minimum they should be regulated with all staff given NHS pay, holidays and pensions. We can also look at the consequences. Rather than line in the pockets of private hospital shareholders for the next 4 years, the NHS needs to prioritise investment and staffing to get frontline hospitals open and functioning. So we need to build new campaigns differently. And we need to steal, for example, the management mantra, which can be summed up now in the 10 Ps. Prohibiting profiteering providers and prioritising public provision prevents piss poor performance. We need to emphasise in this 2 things. Public provision is better, cheaper, more effective than contracting out. Think public health versus Serco. Think vaccination systems versus testing. Think NHS labs versus lighthouse labs. And secondly, unlike private companies, public providers have no conflict of interest to obstruct genuine coordination and integration of services. In other words, we need to start to recapture our words and use them for our vision of the NHS. Link it back to the rolling back of all contracting out. Integration is what we fight for, and it's what the market system, privatisation and use of private hospitals make quite impossible. Value for money is what we get when we strip the profit motive out of healthcare and focus on providing services to all who need them, free of charge or means testing, and properly funded through progressive taxation. To build awareness and anger and create pressure on politicians, we need scrutiny in every area of every deal and exposure of costs, contract failures, waste and corruption. I'm hoping people will want to volunteer to help us build a national network of local knowledge, a database of disasters as ammunition. And finally, let's use some ridicule, some humour, and expose the charlatans of the consultancy companies. Management consultants are the people who famously, when you ask them the time, borrow your watch, read you the time and charge you £1,000. We want them out. I want a new series of cartoons. For example, with a crowd around a collapsed person on a pavement, suited person arrives shouting, "Let me through, I'm from Deloitte's." Or a bloke in a suit telling a woman in labour in stirrups, "Yes, I really am a consultant, just not the sort you're looking for. I'm from Deloitte's." We could do more of these. Let's fight together to roll back privatisation old and new and rebuild our NHS. We can't guarantee to win every fight. We do know if we don't fight, we're bound to lose.